Good morning again. Assalamu alaikum. I would like to thank Dr. Kubler and Dr. Aisha for their great invitation, and also thanking the organizing committee. My talk today is going to be about immune-mediated neuropathy, no conflict of interest. Basically, I'm going to talk about basic approach of GBS and multifocal motor neuropathy with conduction block. As other speakers later on, they are going to talk about other immune-mediated neuropathies types like CIDP, paraproteinemia, and also update of GBS maybe next day. So acquired neuropathies represent most of the neuropathy encountered in clinical practice. Still 30 to 40% of neuropathies still idiopathic, need more research on that. Immune-mediated are often treatable and contribute around 9%. A lot of classification in the literatures for immune-mediated neuropathies, but this is the most common form of immune-mediated. The acute inflammatory demyelinating polyneuropathies, GBS and its variant, CIDP, it is typical and atypical form 2. Multifocal motor neuropathy, vasculitis, and peripheral neuropathy associated with protein abnormalities. My first talk about clinical and basic approach of GBS. So the pathophysiology of GBS actually started like other immune-mediated peripheral neuropathies by mimicry or factors like infectious causes, which really alter the inflammatory systems in the blood because of the weak blood-nerve barrier, especially at the roots, and that's why in GBS affect more the roots and cause radiculopathies. Then when the inflammatory systems enter the blood nerve barrier and affect the nervous systems, well, definitely the autoreactive T cells and macrophage that invade the myelin sheath, axonal membrane, and the node of Ranvier, causing the weakness and the symptoms in GBS. There is a few or many actually antibodies, and there is a list of anti-ganglioside antibodies with also linked to different variant of GBS. The basic clinical features of GBS, usually symptom typically develops rapidly over days or weeks. And the first symptoms usually start by hyperesthesia or numbness, especially in the feet. They later on and also associated with tingling and numbness and the distal limbs, and then followed by weakness. Usually is ascending type of weakness, symmetrical, affecting the lower limbs, then affecting the upper limbs. There is frequent exception to this pattern of progression, and that's the term variant GBS came from this variant of presentation. Pain is common in GBS and may overshadow the presence of weakness. So it is often reported at low back pain or burning or aching pain, and it's not surprised when you see patient coming with lower limb weakness and severe back pain, and you suspect maybe radiculopathy, and from the emergency later on 1 day or 2 days coming back later on with a flaccid paralysis. So that need clinical, careful neurological and clinical examination. In order, usually in the acute period, shows symmetrical weakness with areflexia. Areflexia is a clinical clue usually for GBS. At a neurological presentation or consultation, usually you see most of our patients with GBS almost has like bilateral upper and lower limb weakness with almost facial weakness too associated. Areflexia is seen in about 70% of patients in the course of disease and became nearly universal at the progression or at nadir. There is objective sensory loss, usually is mild, mostly subjectively like hyperesthesia and tingling and numbness. Neurological examination, again, some patients have oculomotor paralysis even early in the course like Miller-Fisher type variant of GBS, and autonomic instability is common, usually manifesting as hypertension, hypotension, or arrhythmia, and that's need to observe your patient carefully on the acute period. Urinary retention, gastric distension, and ILS occur in around 10 to 25% of patients, especially if the patient already presented with quadriparesis. So the investigation in GBS and other immune-mediated, but in GBS mainly elevated protein around 80% with the white normal cell count usually normal. If significant pilocytosis more than 20, you have to look for infectious infiltrative causes or other neoplastic. The main, or the, like, we cannot say the gold standard, but one of the most important investigation that we need to do if we suspected GBS is the electrophysiology. Early on the course can be normal, but later you might see in the early nerve conduction, you might see only delay or absence of F waves. Evidence of demyelination, such as any other demyelinating, like moderate or severe slowing of motor nerve conduction, motor delay on the motor latencies, conduction block, temporal dispersions. These features also you might see it, but it takes like 2 weeks at least to appear and to be more obvious. Needle EMG shows reduced recruitment and high firing rates and fibrillation potential and positive sharp waves, and it takes 2 to 4 weeks when the axonal involvement started. As we heard yesterday about the MRI, it has significant role on myopathies. Also, MRI has now a very important role on the diagnosis of peripheral neuropathies. Gadolinium enhancement of the spinal roots may be seen in MRI, and selective anterior nerve, especially for the anterior nerves, or coda equina enhancement appear to be strongly suggestive, and in certain literature reach even to 83%. We didn't usually routinely do MRI for GBS if it is a classic and clear, but we retrospectively see patient with roots enhancement when we do the MRI to rule out other causes, especially in a variant or atypical presentation of GBS. Management quickly, he usually admit this patient, monitor closely during the acute stage, as 25% of these patients may develop respiratory failure and need to be in a HIDE or in an ICU. Either plasmapheresis or IVIG is the proven treatment of GBS. Corticosteroids are not effective. General measures, please don't be forgotten, especially the neuropathic pain treatment, laxative for constipation, DVT prophylaxis, early physiotherapy and occupational therapy as passive rehabilitation need to be started when the patient is already stable. So who's really better, IVIG, plasmapheresis? Randomized controlled trial demonstrate that plasmapheresis may shorten the time to clinical improvement. But head-to-head comparison study showed that IVIG is as effective as plasmapheresis in improving neurological outcomes. Combination treatment with plasmapheresis followed by IVIG does not appear to provide any additional benefit. The selection of 1/1 so is dependent to center, case by case, if there is any contraindication to either one of them. It is in the weekdays or in the weekend, because sometimes it's difficult to have plasmapheresis in the weekend in center. So in clinical practice, giving another course of IVIG, we do that sometimes if the patient show progression or no significant improvement. But usually we wait for at least 2 to 3 weeks to see the IVIG to take its effect actually. Prognosis, the long-term prognosis is good. 80% of patients are able to walk by 6 months, but also they reported 2 to 6 of these patients of GBS may have relapse. Death is uncommon now with good supportive care. Egg over scarcity, preceding diarrheal illness, low CMAP amplitude, severe weakness at nadir are associated with less optimal recovery and also report as part of factors for poor prognosis. So my next talk, which is the multifocal motor neuropathies, MMN, is already touched a little bit on the talk with Mohammed and Dr. Dimashqi in the morning. So this type of motor neuropathies is uncommon, purely asymmetric motor neuropathy with predilection for upper lip involvement. The clinical presentation of MMN can mimic motor neuron disease, as we heard in the case presented in the morning today. But you have to look for upper motor neuron sign. If you are lucky, look for tongue fasciculation to help you on that too. The tricky things between MMN and ALS have more predilection for myotomes, whereas in MMN, more preference to peripheral nerves. So you have that clue if you are lucky. So serological evidence of anti-GM1 antibodies and conduction block are helpful diagnostic clue for MMN, and we look for this too carefully in order to support other diagnoses. It is under-recognized, prevalence 0.3 to 3. The pathophysiology, as other immune-mediated neuropathies, serum level of IgM antibody against ganglioside was found. And interestingly, why this patient, this disease is more preference to motor, because also the GM1 found more abundant on the myelin of the motor nerves and at the node of Ranvier and adjacent paranoids too. Other antibodies like GM2 and GD1B is also seen but is rare. The response to immunotherapy to IVIG make this type of disease an autoimmune etiology in its pathogenesis. So several mechanisms explain the membrane abnormality and the conduction block and why this very really pathognomic features for this disease. So because of paranode demyelination, one of the explanation, disruption and dysfunction of sodium channels, and also sodium-potassium pump hyperactivity too. So a clinical feature usually subacute onset, patient presenting after a few months to you, and asymmetrical weakness. Weakness start as mononeuropathy, usually in the distal upper limbs, preference to radial nerves with the rest drop usually, spread to the contralateral hand and both legs. Infrequently, the disease may start in the legs, like foot drops or in the proximal muscles. No sensory involvement apart from subjective, only sensory, like patient complain of discomfort, cramp. On clinical exam, weakness in symptomatic nerves and asymptomatically. You will find patient not complaining in the other arm, for example, but you found on clinical exam some weakness there. Fasciculation and cramp may be present too. Muscle bulk usually preserved until late on the course of the disease. No sensory loss apart from vague sensory, as we said, but later on the disease, certain literature reports some vibration loss on test, but few only. Stretch reflexes are usually quite variable, maybe absent, may be present. Involvement of the cranial nerve, bulbar muscle, phrenic nerves is rare on this disease. A lot of clinical criteria raised. What I'm going to present here only focusing on the clinical criteria, but there is a lot on European society committees about including clinical, electrophysiological, and also the serological, and even for the conduction block, they have certain criteria. So it is an extensive criteria. No time to go through this criteria actually. But the clinical criteria, you need to have slow progressive or stepwise progressive of more than 2 motor nerve at least for more than 1 month with no sensory involvement. Supportive features is important, like predominant upper limb involvement, decreased or absent reflexes, absent cranial nerve, cramp and fasciculation, response to immunotherapy. This will support your diagnosis clinically. Exclusion criteria like upper motor neuron sign, marked bulbar, sensory impairment, diffuse symmetrical. If you have these features, you need to look for other diagnoses, I mean. CSF on the investigation usually normal. Serum creatinine, we usually do it because it's part of the motor unit, so it's normal. GM1 antibodies usually high in more than 50% of cases. The neurophysiology test, usually you will see focal demyelinating in motor nerves with conduction block, and that's what we are looking for, and normal sensory nerve conduction study. If you are lucky, you will see also other demyelinating features like temporal dispersion, conduction block, prolonged slowness, and the conduction velocity. EMG, you will see fasciculation and fibrillation potential if there is a secondary axonal damage too. Since we are looking for this conduction block, because it's called from the name multifocal motor neuropathy with conduction block, sometimes for proximal conduction block, it's hard to elucidate it by the neurophysiology. So several techniques like, for example, transcranial magnetic stimulation and triple stimulation can help you on detecting proximal conduction block. And for the triple stimulation technique, usually raise the sensitivity for the criteria from 60 to 90% can help you on that. Also the MRI, looking for the roots or the brachials, especially for the motor preference nerves. It helps you also on in certain cases with, for example, without conduction block. In this study, for example, multiple MMN MRI shows asymmetrical increase signal intensity on T2 weighted image sequence with evidence of nerve swelling in 40 to 50%. And it is helpful when you have highly suspected case with MMN, but without conduction block or seronegative also. So it might help you on that. Multifocal motor neuropathy with conduction and without conduction, seropositive or seronegative, is really show difference clinically or in response to management. is a lot of questions sometimes raised about this. So in a comparative study over a 7-year, the distribution of peripheral nerve weakness and ancillary symptoms like cramps, fasciculation were similar in both groups. And also both groups respond very well to IVIG. And if we compare seropositive and seronegative, certain studies said seropositive show more like weakness with axonal loss and more chronicity of the disease, respond better to IVIG if we compare it with seronegative. However, other studies do not corroborate these findings. So the management of this type of motor neuropathies, several randomized controlled trial approved a good response to IVIG. Periodic infusion, usually interval between 2 to 6 weeks to maintain remission, usually required, and differ from case to case. Certain case, usually in my center because of some logistic admission, every month, usually every 4 weeks, and spare it later on to guests to see if he's on remission. Plasmapheresis, periodic infusion in interval, and plasmapheresis and corticosteroid ineffective in the MMN, and worsening after corticosteroid treatment has been reported. Cyclophosphamide may be partially effective, but its use is limited by toxicity. Azathioprine and mycophenolate are ineffective. Rituximab has been tried with question success. Open label study did not find significant reduction in IV use of rituximab. Actually, here I found some mixed up in the slides. This really treatment for GBS when they shift the presentation. Anyway, for eculizumab now is started to be used in a neuromuscular like in CIDP and myasthenia gravis. But here in MMN, a trend toward an improvement in patient-related rated subjective scores and increased muscle strength. And also they found some decrease in the mean conduction block in electrophysiologic study. This is very original trial, raises a new horizon for the further research concerning the use of complement inhibitors. Finally, immune-mediated neuropathy are treatable neuropathies with proper treatment. Partial or complete remission is possible. Corticosteroids are not effective in GBS, but most patients require more intensive course of corticosteroid therapy in CIDP, for example, and you will hear tonight about CIDP. For GBS, plasma exchange and intravenous immunoglobulin are equally effective in improving neurological outcomes, but plasmapheresis and corticosteroid are not effective in MMN. Thank you very much for your listening.
Thank you, Dr. Abdullah, for this quick, comprehensive talk about GBS and MMN. I think we'll postpone the questions to the end of the session. So for the next talk, it's my pleasure and honor to introduce Dr. Dimashqi. He will speak about typical and atypical CIDP. Dr. Mazen Dimashqi is a consultant neurologist.
No, I don't see it. I have a thumb drive. Do you want to put the thumb drive?
And we are honored to have him here in Jeddah.
Let me get it.
It's not working. Just can you?
Oh, so this would be, let me see, final lectures, KSA. And
Okay. Welcome, Dr. Mazen.
Okay. I'm going to go ahead and get started. I first want to thank the organizing committee for inviting me to speak. It's a pleasure and an honor to be here to talk to you about typical and atypical CIDP. And I think the previous speakers have really laid the grounds for me. I will refrain from talking about therapies because I know Dr. Al-Madani will be discussing therapies in details. Now, I've been doing this field of neuromuscular disease for 25 years, so I can share with you my badges of honor of consultantships, research grants, and whatnot that are perceived potential interest conflicts, but in reality, you'll see they don't apply here. So what's typical CIDP? And that's where we start our journey here, and I'll try to get us caught up. I think I've taken out enough slides that my talk can be delivered in totality in 20 minutes. This way we don't miss noon prayer. That's very important. We cannot postpone that, of course. Now, CIDP is defined as a disease that progresses over 8 weeks. Typically, it's chronic progressive. In younger people, it can be relapsing remitting. We know multiple sclerosis is most commonly relapsing remitting. It's the counterpart when it comes to CIDP, it's more chronic progressive. We like to see demyelination on nerve conduction studies, and I'll show you what that means here in a moment. But it's gotten a bit more complicated because while phenotypically we think of CIDP as causing proximal and distal weakness, we now understand that there are some distal phenotypes that have to do with some of the lesions that are typically at the node of Ranvier. And we like CIDP, we like to see it, because besides treating neuropathic pain, which I will talk about tomorrow, we have the capability of reversing weakness and improving mobility and reducing disability in patients. But I have to caution all of us in the room, because I'm going to ask you a quick question. How many CIDP patients do you think there are in the Jeddah area? The 4 million people, the rough prevalence of neuropathy, if I take the US percentages, is about 5%. Out of all neuropathies, CIDP is 1 in 1,000. So there's about 200 cases of CIDP and many more cases of diabetic neuropathy, cryptogenic neuropathy, and other neuropathies in this area. So I don't want us to think after the talk today is that every case of neuropathy you see is CIDP. So let's try to define what that is, what that bird is, what that patient characteristic is that will make you think about CIDP. It's important that the neuropathy is symmetric, that there is proximal weakness. Now, hip flexion weakness of 4+ is not uncommon in someone who's deconditioned, who's elderly, who's not that physically active. So if it's selectively that, I don't take it as full face value to support proximal weakness. I would like to see more profound weakness. I would like to see other proximal muscles being weak to support the diagnosis of CIDP, but also not in the leg, but also in the arms, in neck flexion. That's powerful when the patients are weak in those areas. It's progressing over more than 2 months in the weakness. It's different from GBS. GBS patients will still be weak at 2 months, but they're not progressing in their weakness. They don't tell you, I'm gone from walking independently to walking with a cane, then now with a walker, and now in a wheelchair over the course of 2-3 months. They're still weak to the same degree, GBS patients. CIDP patients progressively get weaker and weaker. And there's involvement of neuropathy of the sensory system and hyporeflexia. Classically, we think of spinal fluid evaluation where CSF protein is elevated. We like it to be above 60, but with aging, we'd like it to be above the age of the individual. If someone is 80 years old, their normal is 80. But of course, if they're diabetic, the cutoff may be over 100. You don't want to see much in the way of white cells. And there's demyelination on nerve conduction studies. We do not do nerve biopsies anymore because we have good clinical ways of diagnosing CIDP and it's potentially responsive to therapies. Now, these are taken from the 2 different sets of criteria that are electrophysiologic criteria for demyelination. One of them is a classic set of criteria established back in 1991, refined in 1999. These are called the AAN criteria. That's on your left side of the screen, but they're tedious, they're cumbersome, they require many nerves to be affected. Specifically, they have to have 3 out of 5 nerve conduction findings, but each of those nerve conduction findings includes 2 nerves. You're talking about 7 or 8 different findings on nerve conduction study. Therefore, they're not highly sensitive, but they were perfect for research studies. So with that, you will miss CIDP electrodiagnosis in the suspected patient. So first, it has to be suspected patient, not a diabetic patient with numb toes, and you see this. That doesn't mean anything because diabetic neuropathy is axonal demyelinating. We're talking about someone with proximal and distal weakness, and you see this, and therefore you suspect it. But the sensitivity, as you see here from the screen, is really quite low. It's only about 40% in the bottom of the screen. So the EF and SPNS criteria in 2010 revised findings so that it's only two nerves showing demyelination, but it could be a slow latency or conduction velocity, and it makes it easier and with higher sensitivity to diagnose, therefore, CIDP, 87%, but you know the balance, sensitivity, specificity. You increase sensitivity, you lose some on the specificity, and therefore it's about 80% specific. What are the therapies? I will not delve into the therapies of CIDP. Dr. Al-Madani will cover that. Just suffice it to say that we know we have three therapies that we know are effective: IVIG, plasma exchange, corticosteroids, and this is from a survey in the US of from the GBS CIDP Foundation of patients with CIDP as to what therapies they're on, and the predominant therapy is IVIGs. The second best is corticosteroids, and there are others that are listed here, plasma exchange included. Now, not in Saudi, I understand, not in the Arab countries yet, but in the US, as of last year, subcutaneous immunoglobulin became a different way of administering immunoglobulin in patients' home and independence as a maintenance therapy. This is not meant to treat new CIDP, to start them on immunoglobulin. They're already on IVIG, you convert them to subcutaneous. Now, what is the right dose of immunoglobulin? We do not know what the right dose for immunoglobulin is for treatment of CIDP. If you look at the EFNS-PNS criteria, it gives you a broad range. It tells you anywhere from 0.4 to 1.2 gram per kilogram, anywhere from every 2 weeks to every 6 weeks, and you have to periodically do dose reduction. That's important, dose reduction. Now, if you look at this other study, the next bullet point, of a large number of patients with CIDP and MMN, a good proportion of these patients, up to 20%, were getting treatment at 2-week intervals or less. So the interval of treatment, the dose of treatment is not well established. So there are some studies going on. One of them is called PROCID. And in the PROCID study, we're trying to establish what dose of immunoglobulin is optimal. Is it 0.5, 1, or 2 grams per kilogram given every 3 weeks of IVIG after an induction dose? And nearly a third of CIDP patients are cured. And I'll come back to that. They're cured or in remission. And it's important when you start your patients who has CIDP on IVIG or steroids to try to taper them off therapy about a year out after you start therapy to see if they are needing to stay on treatment or they're one of the 33% that are in remission or cured. So this is from the EFNS-PNS criteria. You saw something similar earlier from Dr. Al-Salti pertaining to MMN. This is the criteria pertaining to CIDP. So I'm going to switch gears and talk now about atypical CIDP for the rest of the presentation. And this is a problem group. It's a problem group diagnostically because these are opportunities for error. But typically what we're talking about, remember that I said CIDP is symmetric? What if it's asymmetric? Multifocal variant called MAD-SAM, for example. I said proximal and distal weakness. What if the weakness is only distal, or like DADS type neuropathy, distal acquired demyelinating symmetric neuropathy? We said it's going to affect the arms and the legs. What if it's only in one arm or one leg, like a reticuloplexus presentation? I said it's sensory and motor. What if it's purely sensory or purely motor CIDP? And this is where we get in trouble in overdiagnosing CIDP, the atypical variant. So let's talk about the problem also is 20% in some of the case series, 50% of the cases of CIDP may be atypical. And here you see MAD-SAM, periparetic, where it's like variant, DADS, which could be DADS-I when there's no monoclonal gammopathy, or DADS-M when there is a monoclonal gammopathy, and there's some weird variants called CanoMad and CISP. So let me touch on the pure sensory variant. And you may have seen this sometimes. Someone comes in with numb toes, you do nerve conduction studies, you're not expecting to find much in the way of demyelination, and all of a sudden the nerve conduction study shows profound demyelination. This is called minimally symptomatic CIDP. What do I do for these patients? Do I treat them with IVIG? No. Do I treat them with steroids? No. Do I do plasma exchange? No. They are subclinical. They have minimal symptoms. I don't treat a test. I treat the patient. If they have only have numbness in their toes, I follow them expectantly. I tell them, you may develop weakness. If you develop weakness or ataxia, call me, because now CIDP has become active. Was slowing of conduction velocity. They had numb toes. They were treated for something that's not CIDP, and thought was inappropriate. ALS patients misconstrued as having CIDP. Fibromyalgia, just pain, diffuse body pain. If you hear that, this is not CIDP. CIDP is not a fibromyalgia type of presentation. Idiopathic neuropathy, meaning patients who have what we call C-SPAN, cryptogenic sensory neuropathy. That's one of the confounders, and there's a whole list of them listed on this slide. So how often did this occur? It turns out that it occurred quite frequently, but what's more worrisome, if you use those EFNS, PNS criteria, about almost half of those patients fulfilled the clinical criteria. So we say, fine, well, what about the electrophysiologic criteria? About 15% of those patients fulfilled those electrophysiologic criteria. But the situation is not desperate. There are clues for you to know that you're dealing with something that's a mimic of CIDP, but is not CIDP. And these are the clues. Someone who's not weak. If you have someone without weakness, don't think this is CIDP. There has to be weakness. Atypical CIDP, those one leg, one arm, or pure motor, pure sensory type of CIDP, or the MADSAM, this is a trap. Suspect you're dealing with not CIDP, with another diagnosis. If there's no gait disability, no ataxia, another reason to suspect that. The chronic fatigue, the fibromyalgia patients with predominant pain or fatigue, you should suspect that this is not CIDP that you're dealing with. Someone who has bowel or bladder incontinence, orthostatic insufficiency. I've had one patient seen at the Mayo Clinic where they came back to me, treated for CIDP. I diagnosed her with familial transthyretin amyloidosis. So she had autonomic manifestations. That was the clue. CIDP diagnosed basically on nerve conduction studies. We're all electrophysiologists. We like to rely on nerve conduction studies. Don't overdo it. And only when you see legs slowing only in the leg, that's also big red flag. And if they don't respond to treatment, also that's something that is a red flag for you. Now, we're going to talk very briefly about nodopathy. I'm not going to talk about all the ones that are known. I may focus on neurofacin 155, but this is a new and troubling concept because this is causing a different form of CIDP that's associated with tremor, associated with sensory ataxia, and associated with distal weakness predominant rather than proximal weakness. And if you look at all patients with CIDP, anywhere from 10 to 15% of patients have those types of autoantibodies, but the number could be bigger than that. Neurofacin 155 is the one I will talk about primarily. It's like a glue that sticks the Schwann cell to the axon at the level of the node of Ranvier. And it's an IgG4 antibody, and we know that IgG4-mediated diseases tend to respond to rituximab, and that's what the case is when it comes to neurofacin 155-mediated type of CIDP, which is distal, associated with tremor. There's distal weakness, hyporeflexia, but also there's central nervous system demyelination in 1 out of 4 cases. It's refractory to IVIG. I will not discuss 140, 186, but there's a variant. I will not discuss contactin 1 antibodies, but there's a variant of that. And I will not discuss Casper because there's another variant of that. So what is the prognosis of CIDP, and why are we so excited, even though there's millions of people with neuropathy in Saudi Arabia? Why are we excited with a small handful, those 1 in 1,000 patients with neuropathy that have CIDPs? Because we can change their mortality, we can change their disability. And this is looking at the Mayo Clinic data from 1975 and comparing it to 30 years later with treatments that are available, steroids, IVIG, and plasma exchange. Mortality is down, disability is down, patients' return to work is up, and that's powerful. This is looking at it from a different perspective. This is work of Ken Gorson and his colleague, looking at more than 100 patients with CIDP and looking at their long-term outcome. Remember, I talked about 1 out of 3 patients with CIDP will go into cure or remission. This is where the data comes from. This is surveying patients with CIDP, and whereby over 5 years off of treatment, 11% of cases were off treatment. About 20% of the cases were off treatment, but less than 5 years, and there were about 44% of the patients that were at least 1 year on treatment, but had active disease that required treatment. But notice there were about 20% of cases that were unstable. So, to conclude, I think the typical CIDP phenotype occurs in the majority of CIDP patients. The FNS criteria help increase the sensitivity, but you have to be careful that they're not highly specific. 80% is pretty darn good, but you know what? It could do better. They're atypical variants, and so it's important to recognize them, but you have to be extremely, extremely skeptic about them when you see them and be ready to pull the plug on treatment, particularly when you realize that it's not working within the first or second treatment. And about up to a third of CIDP patients go into remission, and therefore it's important at 1 year after treatment to start either stopping treatment or tapering treatment so that you don't continue potentially harmful and expensive therapy unnecessarily. So with that, I will stop here. I know there's no time for questions, and thank you for the time allowed.
Well, this is great. You just finished on time with an excellent presentation, Dr. Dimashqiya. The next speaker is Dr. Abdulaziz Al-Samman. Dr. Abdulaziz is a consultant, pediatric neurology consultant at King Fahd Medical City in Riyadh. And Dr. Abdulaziz will speak about CIDP in childhood.
Not this one.
دكتور عبد العزيز، عندنا مشكلة في اللابتوب شوية، معلش. خلاص FN5.
في فيديوهات كثير خلينا نشوف. نطول نفتح. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you, Mr. Chairman, and it's a pleasure to stand here before you presenting a rare condition affecting our children, which is childhood CIDP. I'm working in a tertiary care hospital in Riyadh, and it's one of the main referral hospitals from one of cities in Kingdom of Saudi Arabia. And over the last 10 years, we had about 12 cases of CIDP confirmed in our hospital based on clinical criteria and electrophysiological criteria. And at the same time, after seeing these patients and follow-up of treatment, I thought it's good to present them and share you our experience with these patients. So initially, I will talk about childhood CIDP in few words, then I will comment on our cases and their treatment. So, as you know, CIDP, it's mainly an adult disease, but it can occur at any age, starting from infancy to even late adulthood, and it's increasing in prevalence with advancement of age. The other issue in children, it's usually present with slowly progressive or relapsing episode of gait ataxia, distal asymmetric weakness, and paresthesias. It has a preference in comparison to adults. Probably you will have one child, or it's probably in adults 4 or 5 times what's happening in children, and the prevalence in childhood is less than 0.5 per 100,000. And due to rarity of disease conflicting or affecting there is no much of written about the definitive protocol to treat these patients. The diagnostic criteria is very important to remember to differentiate from other disorders like Guillain-Barré syndrome, hereditary or other metabolic or childhood polyneuropathy. But I don't think we have that much of differential diagnosis in comparison to what you see in adult people. And the revised diagnostic criteria for childhood CIDP were created after international workshop based upon available evidence and expert opinion. And different from the adult CIDP, the progressive muscle weakness over at least 4 weeks instead of 8 weeks, that's one of the clinical criteria, or rapid progression, like GBS-like presentation, followed by a relapse or protracted course over 1 year, plus areflexia or hyporeflexia. So several cases or several case series of childhood CIDP have been published in the literature, and in one of the studies, a combined data of 12 case series, a total of 140 patients showed that the disease course is often relapsing or polyphasic in around 60% and monophasic in around 40% of cases. You are familiar with the modified Rankin scale. It's from 0 to 6. So, I mean, usually you see patients between 1 to 5. 1 is the no significant disability despite symptoms. 2 with slight disability but does not need assistance. 3, moderate disability and require some help or some assistance. And moderate, number 4 is, or MR S4 is moderate severe disability with unable to walk without assistance. And number 5, or the MRS5, severe disability, which is bedridden. The treatment course of this patient, there is no randomized trial regarding first-line treatment therapy in pediatric patients. However, it almost parallels the treatment used in adult patients. And this is the summary of the, just to mention a few things more about CIDP. Overall, children with CIDP have more rapid onset, greater disability at the peak of the disease, more than what you see in adults, more frequent relapsing, and that's very important to remember in this slide, more frequent relapses caused than do adults, and response to treatment is better, and they have better prognosis or better outcome. So overall, treatment response of childhood CIDP at any stage of disease appear to be similar if you use both IVIG or steroids in the range of 70 to 80%, but less response to plasma exchange than what you see probably in adults. So what's next? I'm going to present 10 childhood CIDP patients seen in our clinics over the last 10 years, actually 12, but I could not retrieve the whole data of 2 patients, so I limited to 10 patients. And you can see in this table the 10 patients, and the most important in this table to focus at is the disability scale, motor or MRS. It was in the range of so the modified Rankin scale here is in our patients ranging between 3 to 5. And all of these patients, prior to acceptance to KFMC, they had 2 or 3 lapses. One of them, which is the first one in the table, he had probably 6 relapses before referral to our hospital. And after seeing, we find after going through the cases, there were 6 females and 4 males with age ranging from 1.5 years to 9 years at presentation. And the mean incidence is estimated that's out of the patients come to our outpatient clinics, 1 in 2,000 to 1 in 2,500. 90% of them were from outside Riyadh region, and that's very important to remember, because when I talk about our treatment algorithm, the mean age of symptoms of onset was 5.7 years and ranges from 1.5 to 9 years. So they could be as early as 1.5 years. That's the youngest child we had. The mean time between symptoms onset and maximal disability was 2.8 months. And the mean modified ranking scale at presentation out of those was 4.2, so it's the more to the severe type. And the disease course was monophasic in 10% of cases and relapsing remitting in around 90% of cases. That patient, the one who was monophasic, who was actually symptomatic for 7 months. He presented to our hospital after seeing many other hospitals. So he was diagnosed after 7 months. That's why I call it monophasic. No therapy given before that. And most of the children, around 70% of them demonstrate slow or insidious onset. So their presentation, they continue to progress over 8 weeks, and around 30% they were more of acute or subacute presentation, but with no improvement even with IVIG. So I will share with you our patient. I hope the video will work. So this is the first, I don't know why it's upside down, but it's okay. So this is one of the first patients we saw. We gave her MRS scale of around 4, and that's her initial presentation after receiving 2 doses of IVIG. She was from Bisha, and she showed no remarkable improvement. This is the second patient. Also, I said from outside Riyadh, she's from Tabuk, and she has also the same, and that's her representation. She was also probably in the range of 4 MRS. She's again here. I didn't think I. This is the girl whom she was symptomatic for 7 months before presentation to the hospital, to our hospital, and she was severely weak, and she's almost MRS 5. She has received no treatment, just physiotherapy. And this patient from Al Madina, the earlier girl, the one I showed earlier is from Al Qasim. This one is from Al Madina Munawwara. He referred to us after, I think, 2 or 3 doses of IVIG, and it's. So all accepted CIDP patients to KFMC Pediatric Neuromuscular Clinic were managed. So we elect to manage them with combined therapy, IVIG and steroids. And average duration of treatment range from 9 months to 12 months. So this is our protocol. So we divided to the very mild CIDP, and that's MRS1. Then mild to moderate CIDP, MRS 2 and 3, moderate to severe MRS 4 and 5. And these are down there, the protocols. So it depends mainly on the MRS, the score plus the nerve conduction study. Sometimes there is no conduction or 0 conduction. So it's, for example, here, if the patient has MRS cases with very mild CIDP, no significant disability despite symptoms, able to perform all usual duties and activities. So here, I have two options. If the patient from Riyadh, we just elect to follow them, close follow-up and see how. If they are not from Riyadh, we'll give them one dose of IVIG, 2 grams per kg over 2 to 5 days. Then we'll see them in the clinic in probably 1 to 3 months and see if they are progressing or static or improving. If the patient with MRS 2 to 3, which is the slight disability, unable to perform all previous activities but able to look after own affairs without assistance, or moderate disability requires some help but able to walk without assistance, these patients we like to give both short courses but repeated, IVIGs and steroids. So the IVIG will start with 2 grams per kg over 2 to 5 days at 0 time, then reduce the dose 1.5 grams per kg over 2 to 5 days after 3 weeks, then reduce the dose to 1 gram per kg over 2 to 5 days after 6 weeks for 2 times, then discontinue. And steroids also start with 2 milligrams per kg per day, maximum 60 milligrams. Then these doses will divide it. I will give it Q6 hours for 5 days, then reduce the frequency to Q8 hours for 5 days, then Q12 hours for 10 days. So I will continue that probably between 6 months to 9 months. And for the MRS 4 to 5, with moderate to severe disability, with either unable to walk without assistance or bedridden, so we use also IVIG steroid with different regimen, slight more of doses of IVIG and steroids. So we'll give 2 grams per kg over 2 to 5 days at 0 time, then after 3 weeks. Then after that we'll reduce the dose but give it every 6 weeks for 2 times, then 1 gram per kg every 6 weeks for 2 times. For steroids, the weaning course will be slower than the MRS 2 and 3. So in patient follow-up, there was no major events encountered, and steroids, long-term therapy, and all needed precautions were taken into consideration. Following their bone profile, give supplements with vitamin D, with calcium, and measurement of blood pressure and sugar, especially with higher doses, and there were no major side effects encountered. Plus regular clinical and electrophysiological follow-up, so we see them every 3 months, and we follow the baseline nerve conduction study probably after 6 months, then probably after 9 months when we start or decide to stop therapy. So the mean modified Rankin scale decreased from 4.2 at presentation to 0.3 at last follow-up. But I should say here, most of them, they are walking after 2 months. None of them had relapse except one, and that's the first one who referred to us after 2 years of trials and failure of IVIG for probably 5 or 6 courses. So we put him in this course. He improved a lot. Probably he required minimal amount of IVIG, minimal, just every other day, 5 milligrams of prednisolone, plus the IVIG, we are giving it every 3 months instead of every month at the start. 5 patients are off treatment for 1 year or so and continue to do well. So this is the, I don't know if I hope it will work. This is the first girl this is after 1 month of treatment. For sure, we have in our hospital that we have a rehab hospital, and that's is of great help to us. We refer our patient to them after the initial IVIG and steroids. They will refer them. Most of them they stayed for around 6 weeks to 2 months in the rehab hospital. This is the girl after 4 months of treatment. Now she is walking and running also. This is the girl from Tabuk. This is the rehab hospital, and this is after 1 month, I think 6 weeks from therapy. This is the similar one. This is the initial, the girl who was symptomatic for 7 months before treatment, who was almost totally paralyzed. This is her after 2 months of therapy. She was in rehab hospital. She stayed around 3 to 4 months in rehab to recover. And this is her after 6 months. Sorry for the videos, but I don't know what happened to me. And this is the boy from Al Medina, also 4 months after rehabilitation. So in conclusion, early CIDP diagnosis and proper treatment plan are essential key elements for incomparable excellent outcome. So it's very important to pick up these cases early and start therapy as soon as possible. Why is that? Because the first patient who was delayed for around 2 years is still, till now, after 5 years, still have recurrent minor relapses, but he still needs therapy. In a big country like Saudi Arabia with sparse specialized neurologists, it's important to follow unified treatment protocol. And having such a protocol is cost effective in the long run. And where patients can be managed in their home city or hometown and revisit the tertiary care hospital every 6 months or so. And the proposed treatment algorithm should be flexible and linked directly to patient MRS, clinical recovery, and nerve conduction studies. Thank you for your attention.
Thank you, Dr. Samman, for your presentation. It's my pleasure to introduce Dr. Abu Bakr Al-Madani. He will present the treatment approach for refractory CIDP. Dr. Abu Bakr Al-Madani, he's adult consultant neurologist, neuromuscular specialist, chairman of neurology department in Rashid Hospital, Dubai. Welcome, Dr. Abu Bakr.
Thank you very much, Mr. Chairman. It's always challenging to talk after 3 excellent speakers. And my talk would be a treatment approach for CIDP and atypical CIDPs, recent update in CIDP. And always in my lecture, I try to do some change in philosophy. And we have few approach in CIDP, and I'm hoping in this lecture, some approach will be changed and some era will be started from this after this lecture. So typical scenario here. I have a 70-year-old guy who's been diagnosed in Mayo Clinic with CIDP. He's very wealthy. He has diabetes typically as other people in Gulf City. 25% of our population have diabetes. And imagine you tell him, I'll start you, he's 70 kg, I'll start you in prednisolone for 2-3 months until your symptom becomes stable. And the usual course would be 1 milligram per kg. And you concomitantly start with steroid-sparing medication, either Celseptum, Imuran, and will take time, 6 to 9 months to act. What would be his reaction, you think, Dr. Mazen? Do you want to start with steroid? I don't want to gain weight. I kept my weight for 70 years like this. He was thin. That's typical scenario. What would be your answer here? Well, do you have an evidence that the IVIG is superior to steroid or steroid superior to IVIG? I'm hoping with this lecture, I'd be able to tell you what things I would do. So IVIG or steroids? Well, we have randomized trial we've done at least on approximately 300 patients. They compared IVIG versus steroid in 6 months. And they found out that IVIG is more tolerable and more effective in 87% in 6-month time versus corticosteroid, which is effective in only 47.6%. So that's a change in them. So probably early on in the treatment, you would start with monthly course of IVIG. But longer studies showed if you stop, you cannot keep IVIG monthly course for 3 years. Number one is very costly. The number two, the admin might fire you. Time to relapse after stopping IVIG is 4.3 months versus an IV methylprednisolone is 17 months. So if you stop IVIG right away, your chance that you relapse is shorter than the IV methylprednisolone. So that's an extra news that, well, you probably will start with IVIG, but later on you may bridge it with IV oral, either oral prednisolone or IV methylpred monthly course. Well, when you start IVIG, imagine you start in one course for 5 days, the patient doesn't improve. Is it enough? Well, we have studies here that you need to continue, but they respond probably very well to rituximab as opposed to other CIDPs. So in intractable CIDPs, rituximab, interferon, methotrexate were entertained. They don't have good outcome. But in anti-MAG antibody or other associated hematological malignancies, rituximab may be beneficial. Few anecdotal trials done in few patients, Tysabri actually, natalizumab might be effective in few cases. Well, many patients can come to you and tell you, well, doctor, can I go with stem cell transplant? Especially in very intractable cases, right? I had one patient who was very intractable. He had underlying CMT as well, and he got CIDP on top of it. He had CIDP and he moved to CIDP. I tried everything for him, and I told him, go for hematopoietic stem cell transplant. Do I have evidence for this? There is one good evidence tested on 11 patients who failed 2 conventional treatments. 8 patients were drug-free remission for 25 months. That's very good response, right? Though 3% relapsed after only 11 months. So if you run out all of options, you can try hematopoietic stem cell transplant. But bear in mind that most of them had reactivation of CMV and EBV, and they were associated. At least 2 out of 11 had morbidity and mortality. We don't need to go across this, but there's one entity you need to know, the circuit one, the anti-MAG antibody. They respond much better to rituximab. So if you have anti-MAG antibody, which is DANS, consider treatment with rituximab. A new entity is coming, which is, we have the master here, Dr. Mazen, who knows better than you this, subcutaneous immunoglobulin as a maintenance treatment. The studies were done comparing it with placebo, and it showed effectiveness in percentage of patients with relapses or withdrawal during the first 24 weeks of the study. Subcutaneous immunoglobulin was compared with IVIG as well. It showed similar efficacy, though the time of onset is a little bit delayed with subcutaneous, but the maintenance or the treatment or the improvement would last longer than the IVIG group. So subcutaneous immunoglobulin is as effective as IVIG. The kick-in time is longer, but the maintenance treatment or the maintenance of the disease would be longer. So time to reach to primary endpoint is also better. The higher the dose, the better. So 0.4 gram per kg is better than 0.2. So equal efficacy, subcutaneous immunoglobulin versus IVIG. It's proven as well. So multifocal motor neuropathy with conduction block is another atypical CIDP which should be considered. IVIG is the mainstay of treatment and improving in 70% of patients. Subcutaneous IG was approved to be beneficial in multifocal motor neuropathy with conduction block as well. Those patients may improve in anecdotal trials and rituximab should they fail IVIG or subcutaneous IG. Cyclophosphamide was tried in a few patients who were failing IVIG and showed to be beneficial for short term. So the prognosis, as Dr. Mazen said, 70% of the CIDP will be independent and go back to work. So that's good news. So it's important to address the diagnosis. 10 to 15% will remain in total remission without treatment. In some studies, they claim that 1/3 of the patient go without treatment. 50% though may relapse within 1 year with treatment. And in few severe cases, 5 to 10%, if they go into advanced treatment, they may die due to complication of the disease or due to complication of the medications. Conclusion, so we know now that the oral steroid is good, but you can skip the side effects by using pulse dose of IV methylpred versus short course of IVIG or subcutaneous IVIG, bridging with pulse course of monthly course of IV methylprednisolone. Alternatively, if they don't improve within 6 months, you should think about alternative such as Plex or rituximab. Thank you very much.
Thank you, Dr. Abu Bakr.